Welcome to my channel, Pajon Imaging Hub. In our How to Do series, today we'll look at technical evaluation of chest radiographs. So there are about 11 factors we'll look at. Welcome back. Please don't forget to share this video and click the subscription button so that you'll be notified when new video is released in this channel. We'll look at the technical evaluation of chest radiograph. Things we'll consider when we'll finish obtaining the radiograph before we'll make a clinical diagnosis from the radiograph. The first one is identification. There are particulars we use to identify the radiograph. This is to enable us to know the patient that owns the radiograph, to avoid giving a radiograph to a wrong patient. The particulars include the X-ray number, the name of the patient, the projection we obtained, the date it was obtained, the sex of the patient, and of course the age. There could be other particulars we can use, especially in this era of digital imaging, which allows us to use many particulars to identify a particular patient. In a setting of analog imaging, they use mainly X-ray number and the date the X-ray was taken to identify the patient. In all X-ray, the identification is found at the upper end. This area, that's where you find the identification. But in some instances, in analog setting, the actinic marker they use to place the identification may not come out clearly, so they may still need to write those identification clearer along any free edge that will not obscure the image itself, so they can still write the identification along this line. Now we'll look at the second factor we'll consider. That is the area of interest. We'll try to be sure that the radiograph we want to look at to make a diagnosis covers all the expected area of interest. This is the heart. This is the rib cage. It has to contain the rib cage. Then this line here is the diaphragm. Then of course the soft tissue that surround this. We'll still look at those areas during interpretation of chest X-ray. There could be pathologies in those areas. Now, X-ray is normally obtained in a PA view or projection. Every other views we obtain is good if we're using digital imaging to label those views so that the person using the image will be guided properly. Because most cases, the structures will rely to identify which view was used doesn't in some of the cases appear helpful to give us a clear distinction from the other views. Like here, this X-ray was done is a decubitus view. Now, if you're not told that this is decubitus view, you may not be able to ascertain that this was obtained in a decubitus projection. Now, this opacity here is subpulmonic effusion. Then this other one here is apical view. You see the clavicle is thrown off even above the lung apices. We'll do these views in cases where we want to see clearer this apex of the lungs, these areas. Like this, you can see the clavicle here. We'll try to throw it off by using a cranial angulated beam to throw it off, so we can see those areas very well. Then we'll look at this other one, this one down here. This is a AP chest. In AP chest, what helps us identify is that the clavicle is straightened, is not curved. Like in this other normal PHS, you see the clavicle is curved. See the curvature of the clavicle is maintained. So we don't see that in AP chest. So the clavicle is straightened. Then also comparing AP chest to apical chest, we see that the in apical chest you see that the ribs appear horizontal, but in AP chest it still appear angulated, and there is much distortion of the structures in apical chest. You see how the thoracic cage look compared to this of AP and compared to the other views. So in as much as possible, if we're using digital imaging, please try to identify the views you use. Then we'll look at the anatomical marker. The anatomical marker shows us the left or the right of the image. This is the right, supposed to be a marker there and here to indicate the side of the image. One is enough. If you mark right, there's no need of putting left. There are some markers in analog settings that can mark PA or AP. They exist. Then we'll look at the fifth factor, that is optimum definition. This has to do with details in the chest X-ray. I will be able to differentiate structures from each other. Like in this X-ray is blood. This helps us to be able to know the part of the side of the chest that if we find any pathology, the side it is located. We cannot really see the structures very well. See, the ribs appear to have hairs at the edges. Then you see all these blood areas is not clear, so cannot really state what it is, whether it's abnormal opacities or just the lungs. So it appear blood. So this kind of image need to be repeated to avoid making a wrong diagnosis. Then we'll consider the sixth factor, that is penetration or exposure. We look at this film, this radiograph, we see that this, we can barely see the diaphragm, is not clear, and even the costophrenic angle appear to be blunt, even these edges. So somebody could, this may make a pleural effusion or even a lung collapse. And these other areas can mimic opacities that can signify pneumonia or infection of the lung. So underpenetration of radiograph can lead to misdiagnosis. So such films need to be repeated. Then we'll look at this other one. We can barely make out anything from this radiograph. So it's poorly penetrated films, so it need to be repeated. Then we see this other one. This is dark film. Everything there appear to be dark. We cannot differentiate the structures there. This at times we may get in an analog setting, we may get a good exposure, a good factor that's supposed to give us a good exposure. But when the film is being taken to the darkroom where it's being processed, if it is allowed to stay in the developer for longer than supposed, it can turn the image to become black, irrespective of the factor you use to produce the X-ray. So this could be as a result of such phenomenon. Then we'll look at this other one. In this era of digital imaging, most cases will take it that the film cannot be over penetrated. It can. Films are not expected to be, chest X-ray are not expected to be spinous. Now, even though we can still see the structures in the lungs, but this X-ray is spinous. Probably the patient, the radiographer use higher factor than necessary, or use protocol for another part of the body. He may have used protocol for spine X-rays to produce this chest X-ray. So you know most of the digital X-rays has automatic exposure control. So they tend to control the amount of X-rays they give out in relation to the body thickness. This other one is also over penetrated. It appears spinal just like this one. So this kind of X-ray need to be repeated. Then I want to show you this particular x-ray. So you know the danger of poor uh, x-ray. This x-ray, you can see this tiny structure there. That is a nodule. If this x-ray, this particular x-ray is the exposure is okay, but if it is overexposed, we may lose this nodule, may not be able to see it. It may blend with the other structures, these dark areas, and that will make us to miss an important nodule. And this nodule could stand for lung cancer. So you can see how tiny structure, missing a tiny structure in analyzing X-ray, what it can cause, this consequence of such tiny thing. Now we'll consider the seventh factor, which is inspiration. For radiograph that is produced under poor inspiration, it can cause it can mimic pathology. How do we check if the radiograph is obtained under normal optimal inspiration? We'll count the ribs. The anterior ribs, we're supposed to see uh, 6 or more anterior ribs above the diaphragm. Then the posterior rib is supposed to be at least minimum of 8 ribs above the diaphragm. So how do we count the ribs? These ribs are moving downward is the anterior ribs. This one, this is the second one, the third one, the fourth one, the fifth one, the sixth one. This is the seventh one here. There's seventh one here, this eighth one here. But we can only take this sixth one. The ribs will take has to the last one will accept has to be the one that cut at least at the midpoint of the diaphragm. This is the diaphragm, so it has to cut at the midpoint of the diaphragm. Now we'll count the posterior ribs. This is the first posterior rib, the second one, the third one, the fourth one, the fifth one, the sixth one, the seventh one, the eighth one. Now the ninth one did not cut at the mid or greater than the midpoint of the diaphragm. This is the half of the diaphragm, so we're not going to count it. But the 8 ribs above the diaphragm is still enough to support that the film was obtained under normal optimal inspiration. Now, what the consequence of obtaining film under poor inspiration is that we cannot be able to trust the size of the heart, the cardiothoracic ratio that we use to assess the size of the heart. We measure this and take the ratio of the two to assess the relative size of the heart to determine whether the patient has a feature of hypertensive heart disease. But if the exposure or the radiograph was obtained under the condition of poor inspiration, now this lung cavity will not expand well, so it will appear closer to the heart, and every structure inside here will appear crowded, so we'll not be able to, the ratio will not be correct. It will be misleading. And also the structures that appear crowded can equally mimic pathology. If there is a level of crowdedness, they can appear to look like a density that can signify infection like pneumonia. Then if they are crowded, it may look like these lung markings are prominent, and that can signify CCF, and this will lead us to misdiagnosis. Then we'll look at the next factor, which is rotation. How do we assess rotation in radiograph? We'll look at the distance between the medial end of the clavicle to the spinous process. This is the medial end of the clavicle to the spinous process, this distance. Then we equally look at the opposite side, the medial end to the spinal process. Then we'll compare the two sides. If this one is greater than this one, that means the patient is rotated towards this side that is greater. And so it will help us to know how to correct for rotation when we go to repeat the radiograph. But this we only repeat radiograph for case of rotation when the rotation is gross. This kind of rotation, this one is minimal, so there is no need of rotating the repeating the radiograph. But there is a feature of rotation in the radiograph. It is difficult to obtain a radiograph that does not have any degree of rotation. Now, what is the consequence of having using a radiograph with a gross rotation? The consequence is that it causes distortion of the structures. It can cause distortion of the heart. It can cause the distortion of the vessel. See this vessel is important. We use it to analyze. Is part of the feature we'll consider in a case of hypertensive heart disease, the aorta, whether it's unfolded. So it can distort other structures and make them look abnormal. It can equally reduce the size of the heart or increase it, depending on how the rotation. The ninth factor, which is magnification. This has to do with the relationship between the sensor, what we use to capture the image, the subject, that is the patient, and the FFD. And of course, the view we use or we obtain. Now, normally PA, AP view, and PA will give us a good representation of the sizes of structures of at least the heart, because the heart is closer to the sensor than in an AP view. Now, these two structures are AP view. You see how the heart looks. So we cannot really say that the heart is enlarged. We cannot be that sure because we cannot trust the size of the cardiothoracic ratio in AP chest. But probably the patient, that is the best they can obtain, probably because of the condition of the patient. So we'll still work with it. Then we'll look at the next factor, the 10th factor, which is angulation. This has to do with whether the patient is bent during the time the X-ray was obtained, bent either backward or downward, or whether the beam is projected cranially or caudally. Now, this is a normal PA chest. This other view is an apical view. The beam is projected cranially, so you can see that the clavicle is thrown off away from the lung field, and this helps us to see the apices of the lungs. These are the time we use this kind of view, but in other conditions it is not ideal because it causes the distortion of structures in the heart, in the chest. You see the thoracic cage, how it looked like. You see the heart. You cannot be so sure that this is the optimum contour of the heart. And you see how the ribs are almost horizontal. These are not the kind of structures we want to see as optimum in making our diagnosis. But this particular case is only good for checking the apex of the heart because it helps us to remove this clavicle that is obstructing here. We look at the last factor in our presentation. That is the artifacts. These are unwanted opacities or objects in the radiograph. We look at this radiograph, we can see the necklace. Maybe the radiographer did not remember to ask the patient to remove the necklace before the X-ray was taken. So in such an image, it needs to be repeated. Now this is a lateral chest X-ray. Now, in lateral chest X-rays, the apex of the lungs are not all that wonderfully demonstrated. This is the apex of the lungs, but this one is a normal lateral chest X-ray. The apex is well seen to some good extent compared to this one here. The This is the apex of the lung here, but this shadow here is the arm, the shoulder, and the arm of the patient. It is not well raised above the head. The hand was not well raised above the head, so that causes obstruction of this area. So this is poorly done lateral chest, and it needs to be repeated if it is not due to the condition of the patient. As much as possible, we should make effort to tell the patient to raise his or her hands well above the head so as to clear the shoulder and the arm from the apex of the lung. Thank you so much for listening to this video. Please remember to share this video, and also don't forget to click the subscription button so that you'll be notified when new video is released in this channel. See you next time. Thank you. Bye.